Dear colleagues, good afternoon. Assalamu alaikum. Good to see you back on another evening of Sunday. Thank you very much for sparing your time on this Sunday, which is your family day. The purpose of this webinar is to highlight the important aspects of ERCP in US. And this time we have a very important topic. That's the indications and patient selection. This is the most foremost and most important point in the ERCP. Unless you selected the patient carefully, and unless you have um, um, selected the patient based on a strong indication, remember, you are likely to make mistakes. Gone are days when the ERCP used to be a diagnostic procedure. Right now, we all understand that ERCP is therapeutic, and therapeutic. And since we have to do some kind of intervention, unless you're sure that you have selected the patient in a correct way, meaning by that indications and contraindications all have been taken into the consideration, and the kind of intervention that you want to contemplate in a given patient, you must not go ahead. In that account, you need to sit down with your surgeon, you need to sit down with your radiologist, and you need to sit down with your team before taking up the patient. And to give you a further detail on this subject, I've requested Dr. Ray McCrudden, not a new name in Pakistan. He has been very kind to visit Pakistan now on 3 occasions, and he has been participating in the ERCP and ES education up till now. He works in Royal Bournemouth Hospital in UK. He's a consultant gastroenterologist. He has been on the chair of various important topics in the Royal College of Physicians, most importantly ERCP and ES, and he has been very kind to spare his time on Sunday, a family day. His daughter Kati had to go to the university. She's starting a university. I'm really thankful to you, Ray. All yours.
Okay, I just want to say thank you so much, and it's a great privilege to be able to deliver this talk today. So thank you again for asking me. Okay, so I'm going to minimize, I think, I'm going to minimize my Zoom. So this is a picture of the Dorset coast. Our county where I live in Bournemouth is in Dorset, and that's on the south coast of England. And this is Mute Bay, which has some very special landmarks with rock formations arising directly out of the sea. Perhaps a little bit more of that later. So indications and patient selection. So I'm going to talk a little bit about the basics, because I think we need to know about the basics before we talk about indications and we talk about the individual patient. And then finally, I'm just going to say a little bit about what I see when I walk into our X-ray room 11. That's where we do ERCP at the Royal Bournemouth Hospital. And then I'm going to bring it all together. So what about the basics first? I think once we know the basics, it touches immediately on all of the indications and also the patient selection. So what do we need? ERCP isn't just about endoscopy, it's endoscopy, but it's also radiology and all of that entails, which means knowing about radiation, knowing how to interact and work collaboratively with radiographers and radiologists. I know that I might say to everyone, it's all about me, and it's always all about me, but I think all of you know that that isn't true. ERCP is truly a team effort. And as a team, you are only as good as the weakest member of that team. And of course, that weakest member might be the ERCPist. That might be me, rather than the porter or the HCA or the nurse or the radiographer. And then finally, we might agree that the basics, we've ticked all the boxes and that patient does need an ERCP, but am I the right person to do it? Once we have decided that a patient does need an ERCP, what do they need? So a little bit of word about sedation, and this is really directed more, I think, at our trainees. So I think I view ERCP as broadly 3 types of ERCP. and they are dictated by sedation. So the first and the most common in the UK is sedation ERCP in an endoscopy unit, either with a C-arm or in a dedicated radiology room. And that's traditionally using midazolam and fentanyl. So an opiate and a benzodiazepine. Different countries have different drug regimens. The second type is propofol sedation, which I know is also practiced internationally and, for example, in Lahore in Pakistan. And the third is general anesthetic. This is when each of these three, the sedation becomes more and more invasive. So for a true GA, it means an endotracheal tube, they're ventilated, and they're given intravenous muscle relaxant, so they're paralyzed. For me, I think that the first type of ERCP is by far the hardest. The third is the easiest. Why? Because in the third, the patient is tubed, ventilated, paralyzed. The duodenum moves very, very little. And this is the group of patients which our trainees will benefit from in the very early stages of their career in terms of training and in terms of getting the basics right. Propofol sedation is a variable feast. It can vary between very similar to a sedation, and that really depends on the experience of the anesthetist or the person delivering the propofol. Equally, it can be closer to the general anesthetic side with the proviso that the patient monitoring and the oxygenation and the CO2 levels are closely monitored. So what about other aspects to the basics? So I'm going to touch on consent throughout, really. So when we consent the patient, we really need to talk to them. What are we proposing to do? What are the adverse events? And I try and put this into context in a language that they understand. I think as we get older and more experienced, we tend to use technical language. And sometimes patients remind me that they speak English, they don't speak ERCP. And so I talk in terms of what I feel an adverse event is and what the complexity of that is. Is this scary? Is it very scary? Is it really, really, really very, very scary? And the levels of risk in a language that they understand so that they can weigh up the pros and cons, whether they want to have this procedure or not. Something that perhaps we're not good at doing for any consent is to tell the patient what would happen if we didn't do the ERCP. What would happen if we walked away? And again, sometimes we're not so hot at doing is telling the patient what alternatives to ERCP are there out there if they would prefer not to have it. So in 2015 in UK law, with a doctor, a surgeon that was taken to the High Court, there was a famous ruling in law for medical legal litigation, and that was called the Montgomery Ruling. And it is a new step forward, and it pertains very closely to consent. So the summary of the Montgomery Ruling is this: the doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative or variant treatments. What does that mean? It means that our consent needs to be perhaps more robust than it has been in previous decades. I suspect many, many of us do this anyway in our day-to-day practice, but the Montgomery Ruling made it a standard of care, a duty of care for all types of consent. And again, I'll touch upon this towards the end of the court. But perhaps one question that people might want to talk about at the end of the talk is, how do we prove in court? How do I prove in court that I did take reasonable care when I was talking to the patient? So I'll leave that for you to think about. So what are the material risks in ERCP? Well, there are the local complications that we all know about in terms of perforation, sepsis, hemorrhage, and pancreatitis, I think, and perforation. And of those, I often say to patients that the ones that we are really worried about are perforation and pancreatitis. There are those that are related to sedation, and it's increasingly been recognized now about the aspect of silent aspiration after an endoscopy procedure is over. So the adverse event doesn't necessarily happen during the procedure, but it happens in recovery or when they go back to the ward. What are the other risks? Well, we may not be able to complete what we set out to do. We may have problems, for example, with the cannula in delivering intravenous access, damage to teeth. An adverse event isn't necessarily something that happens during the procedure, but it may be that the patient needs to have further procedures done. And another aspect to this is that patients may need other procedures, for example, interventional radiology or surgery. The reasonable alternatives are walking away, doing nothing, asking them to consider surgery, whether that's open or laparoscopic, and also interventional radiology. So the practical considerations, I think, for consent are broadly this. Consent is a process. It's not just a signature on a piece of paper. And the speed of that process, and I'm going to talk a little bit about that at the very end, is really determined by the urgency. How unwell is this patient? Are they in multi-organ failure and on inotropic support and tubed and ventilated on an intensive care? In that scenario, you have minutes or several minutes to sort out consent. And of course, the patient may not be able to consent. Does the patient have capacity? Can they understand what you're saying? Can they retain that information? Can they weigh up the pros and cons? We might have to ask permission to speak to family about this. And I know that this is different in different institutions and also in different cultures internationally. Can I quote my outcomes? Patients are becoming more and more streetwise in terms of looking up their doctors, looking up the procedure, and then coming to the consultation and saying, how good are you? How good are you, Ray? I've heard that you do ERCP, but I want to know about your cannulation rate. Are you a 90% doctor or are you an 80% doctor where 20% or 1 in 5 you don't actually get in? And Ray, can you tell me about your pancreatitis rates and your perforation rates? So another aspect to getting the basics right is determining safety in ERCP. And again, this is something that we will come back. So indications, which we will talk about, sedation we've covered, age, specific procedures performed. So we have to think about, is this a straightforward ERCP? Is it complex? Is it advanced? Is it going to dovetail into other procedures? We need to think about the setting and the equipment of the endoscopy unit. And we need to think about the people that are involved. And again, that's down to training and competence, both for the ERCPist, but also the nursing and the healthcare assistant team, the radiographers and the radiologists, and any others that are involved. Okay, so let's move on to the next aspect of our talk. So this is a picture of Swanage. This was very much a black and white day. It was raining at the time, and you always have to watch rain with your camera. But I think a black and white day is often the colors are poor, so I can convert it into black and white, and sometimes that can give much more information. So this is Swanage and the Old Pier. So what are the indications for ERCP? Who should we be doing it in and who should we not? I think broadly there are two things to say. There's the indication and there's the risk of complications. And interestingly, they are very, very closely aligned. So the stronger the indication you have, the lower the risk of complications. The weaker the indication, unfortunately, implies a higher risk of complications. And I don't have time to talk about this in this talk, but I'd be very happy to answer questions in terms of types of scenarios and how to anticipate what kind of complications you might have. So what about age? Are you ever too old? Well, I don't believe that you are. I don't think that age is a numbers game, but I do think it is a biological age game. In the last 6 months, I've done a patient who was over 104 years of age, and he did extremely well. He flew through it. But equally, in the last week, I've looked at a patient who was 70, and his biological age was far older than the first patient I've told you about. So I think the headline complication is this. Interestingly, the evidence suggests that the rate of adverse events is lower in older patients. And that's largely to do with the lower pancreatitis rate. However, there is a caveat to this, and that is if when you do get an adverse event with older patients, their ability to cope with it may not be as good as a younger patient. The anesthetic risk is usually manageable, but we do need to be cognizant of severe cardiorespiratory disease. And certainly in our population locally in Bournemouth, that is higher in the elderly. So indications too. So the first thing to say is ERCP is really about therapy. It has been for well over 2 decades. We should really never, or very nearly never, talk about a diagnostic ERCP. So I'm going to talk a little bit about the list, but these are the most important 2 or 3 indications on this first slide. So someone who's jaundiced, someone who has suspected biliary obstruction, and by that I mean someone who's yellow, deranged LFTs or liver function tests. Imaging does highlight that there is extrahepatic bile duct dilatation. All of this is the hallmark of biliary obstruction. Another is a patient who's not jaundiced, but there are clinical or biochemical or imaging studies suggestive of either disease in the main pancreas duct or in the bile duct. Another still is acute biliary pancreatitis, and I'm going to talk a little bit about a case that I was asked about on Friday about whether we should do an ERCP or not. So other causes, so evaluating signs and symptoms for pancreas cancer where the previous imaging like ultrasound, CT and MRCP have not been helpful. However, I would urge you to consider an endoscopic ultrasound first because often that can help in this setting. Another is biliary obstruction with or without liver function changes, but an abrupt caliber change at some point down towards the ampulla. And often in this context, we're talking about an ampullary tumor. Evaluation of pancreatitis of unknown etiology, yes, perhaps in some cases. And pre-op evaluation of the patient for chronic pancreatitis or pseudocyst, again, that's a very tricky indication and would have to be carefully teased out as to what we would hope to achieve with an ERCP. And then another one is evaluation of sphincter body dysfunction with the specific use of manometry in patients. And this is for suspected type 2 SOD. And I don't know anyone who does this in the United Kingdom now. Most units around the country that used to do sphincter body work with manometry have actually closed up their manometry kits, and these are collecting dust on the top shelf in the accessories room. So not many people do manometry now. So one clear indication is that if you are intending to perform a sphincterotomy, so that might be for common bile duct stones, papillary stenosis, so that's scarring of the major papilla, sphincter body dysfunction, yes. It might be to allow stents in or allow you to dilate strictures, sump syndrome, colodococeles, ampullary cancer in patients who are not fit to go for primary surgery. And it might be that the sphincterotomy is there to facilitate access into a particular duct. Aside from sphincterotomy, doing an ERCP will help if you are going in with an intent of stenting. So that's either benign or malignant strictures, fistulae, postoperative bile leaks, and for high-risk patients where there is a stone present, but it's either so large or so difficult you are unable to remove it, and you will help the patient to remain safe by stenting across it until you bring the patient back for definitive procedures, whether that's surgery or further ERCP or spyglass or interventional radiology. Another indication is dilatation of ductal strictures, and another still is balloon dilatation of the papilla. Other indications, placement of nasobiliary drains, pancreatic pseudocyst drainage in appropriate cases, and again, we would have to tease out what people would want to have there. Definitely indicated for tissue sampling, for pancreatic issues or bile duct issues, ampulectomy, as we've talked before, therapy of disorders of the biliary and pancreatic ducts, and also facilitation of other imaging modalities. And by that, I mean cholangioscopy or pancreatoscopy, so that's spyglass. There are some emerging indications, for example, combining ERCP with endoscopic ultrasound, or rendezvous procedures for previous failed ERCP, for example, antegrade EUS access into the main pancreas duct, railroading wires across it into the duodenum, and then picking up these wires with an ERCP scope and then continuing your ERCP. It can also sometimes be helpful in the emergency treatment of walled-off pancreatic necrosis. So, for example, you might wish to consider the primary therapy immediately, which is EUS-guided drainage of that collection, but at the same time, it's obvious that there will be continuing obstruction to the common bile duct, and so an ERCP at that time under general anesthetic may be helpful to stent. ERCP is not indicated in the diagnosis of obscure symptoms. So what do I mean by that? So upper epigastric pain has sometimes historically been a reason to write to us or refer to us. But if the patient has no biliary or pancreatic disease, if they have normal investigations, then it's really not indicated. And we definitely have better modalities now to look at these patients with obscure abdominal pain, such as MRCP and endoscopic ultrasound. ERCP is not indicated prior to a laparoscopic cholecystectomy if there are no signs of biliary obstruction. ERCP isn't indicated either for evaluation of suspected gallbladder disease if there's no evidence of any problems in the bile ducts themselves. And again, for pancreas cancer, it's really not indicated unless the management will truly be altered. So, patient selection. We've got the right indication, tick. We have a slot booked tomorrow morning, as I have, for 3 patients under general anesthetic, tick. What about the patient selection? And are those patients going to be okay? So I think for people who are starting out as service providers, ERCP, if it wasn't a roller coaster ride for their training, it's certainly a roller coaster ride when they start their service provision. And I feel sometimes you have to have eyes at the back of your head to be able to anticipate all things, keep all lines of communication open, and to be able to think about that patient. That patient is the center of your focus in terms of, are they right? Are they safe? Are they fit? And is this the right time to do it? So here is a case that came up on Friday, just 2 days ago. So this is a 45-year-old lady who was admitted 5 days ago. She came in as an emergency through the emergency department with epigastric and right upper quadrant pain. She had fevers, rigors. She was previously fit and well. She had significant risks for pancreatitis, raised white cell count, raised inflammatory markers. Pardon me, and her amylase was elevated above 100. The ALT was elevated above 35 and the alk phos elevated above 100, and the bilirubin elevated above 19. So jaundiced, acute pancreatitis, and the ultrasound shows, in inverted commas, duct dilatation. So the surgeon came down, and surgical houseman, and said, is it okay if we put this case on your list, as one of your colleagues has already reviewed the ultrasound? So this is the ultrasound. We have to, there are two ways that we can review the ultrasound. One is we look at the report, and the second, which is my preference, is to actually look at the images. Now, I don't know how many radiologists are listening in the background, but as all gastroenterologists know, radiologists are an advanced section of the human species. They have X-ray eyes that gastroenterologists don't, so they see much more than we do. Their language is much more advanced than gastroenterologists' terminology, and they do have specific signals that they can talk to each other and communicate secretly with each other. This first line on the ultrasound report is a good example of that. So the sentence says, views significantly limited by patient body habitat. What does that mean? In radiology language speak, in the advanced communication form, that means that the patient was significantly overweight, and let's detail what that means. She has a body mass index of 45 kilograms per meter squared. And what does that mean? It means that the ultrasound penetration through the adipose is very, very poor indeed. Nevertheless, after that sentence, the ultrasound goes on to say the following: multiple sub-centimeter gallstones and sludge, normal caliber walls, no intrahepatic duct dilatation. The common bile duct is mildly dilated at 7 millimeters at the porta hepatis. Pancreas is completely obscured by overlying bile gas. Now, on paper, I think most of us might be happy with this report and go straight for ERCP. But my problem is this: when you start to look at images and you realize that what the radiologist says in the first sentence is absolutely right, when they say view significantly limited, it is a shocker when you actually look at the images and you can hardly see anything. So my own personal preference for this patient for tomorrow morning, because they're on my list tomorrow morning, is that they should have further cross-sectional imaging with a dual phase CT scan. And that has been booked for this afternoon. I was hoping that I could show you these images and put them on the slide set, but the CT still hasn't. I've just checked in the hospital server and the CT hasn't been done yet, but it will be done. It has been booked. So let's talk about patient selection. So before we even talk about the ERCP, what do we need? The upper GI tract must be empty. Generally, we say no eating or drinking. Often for our ERCP list, there are morning lists, so we say nil by mouth from midnight. In truth, our anaesthetists are happy if patients are allowed to drink water, only water, up to 2 hours prior. Current medications, some of these might need to be changed or adjusted or even stopped. Anticoagulation, of course, is one of those. Many meds, however, can be continued. Coagulopathy is important in this regard. Removal of any dentures or loose, well, particularly loose-fitting ones, jewelry, contact lenses, etc. You'll see that this will be a theme of this talk, as I will continuously come back to it. So we should be reviewing all of the previous abdominal imaging, cross-sectional imaging, any previous ERCPs, any cholangiopathy or cholangiography studies or pancreatography studies. In general, deep sedation is desirable during ERCP because it will help allow the ERCPs to get a stable position in D2. That will therefore, in the short position, help to allow proper cannulation. and therapeutic intervention, and ultimately to reduce the frequency of adverse events. So the preparation of the patient is actually dependent on the patient. There are many, many tests that we can do for everyone, but very frequently this is not actually indicated. I think everyone should have up-to-date blood tests for anyone who has a coagulopathy or who has obstructive jaundice, just like this lady that I've told you about. We need very up-to-date coagulation studies, if not on the day of the procedure. But for people who are young and fit and they have no cardiac problems, and they've had a normal ECG in the last few days or weeks, they don't necessarily need to be repeated, nor does everyone need to have respiratory function tests or an echocardiogram, etc. So the specific tests are really dependent on the patient and their needs. One of the things that we do need them to do is to make sure that they can lie flat. So what about contraindications? Well, contraindications may be absolute, and there are actually only a few of those, or they may be relative. So a contraindication is a very, very unwell patient who is essentially unstable. Cardiopulmonary, neurologic, existing valve perforation. These are relative contraindications. Now, it may be that a patient comes in shocked today into the resuscitation room, and yes, ERCP may be contraindicated, but it may be done at a later time, 6 or 8 hours later or the day after, once that patient is optimized, for example, on the intensive care unit or with inotropic support, etc. Another contraindication, and again relative, is structural changes. So strictures in the esophagus, stomach or duodenum. It's more than once I've been challenged by a referral for a stricture and an ampullary problem, only to find that there is a coexistent new undiagnosed cancer in the distal esophagus. And these are cases that really do need to be carefully thought through or done in an advanced center. On one occasion, we were able to get through the esophageal cancer, and we do need to know the caliber of our scopes. For example, a standard duodenoscope may be up to 13 or 13.5 millimeters at the tip. So your caliber of your tumor or your distal fibrotic stricture in the esophagus needs to be addressed as such. Altered surgical anatomy may be a relative contraindication. Coagulopathy, as I've said before, is a contraindication. I think the only caveat to coagulopathy is we frequently see ERCPs cancelled by referring teams because the INR is delayed. Now, in the context of someone who is poorly and has cholangitis, you actually can still do an ERCP in a coagulopathic patient, but you will not necessarily do a sphincterotomy unless the INR is under 1.5. But you could get into the duct and you could stent the duct and allow drainage of pus and infection. So some do's and don'ts in ERCP. So do make sure the patient is fit. Do review the imaging yourself. Ask a radiologist to go over the images with you. Do ensure the blood tests are updated and that coagulopathy is corrected. And do start to anticipate the complications for that individual and prepare for them. Anticipate problems. Sometimes problems are not to do with the patient themselves, but about communication or logistics, or the patient is still in a hospital elsewhere and won't transfer to you until the morning of the planned procedure. So anticipate problems in terms of communication and what their needs are. Do consent the patient well. What are we proposing to do? Why are we doing it? What can go wrong? And if anything goes wrong, what can we do to help? Patient selection, who should get an ERCP? So here is a curveball for you. We've all decided that they should need an ERCP, but should I be the one doing it? After all, how hard can it be? And this is really down to what's anticipated and also the complications that are involved. But selection must consider this. If they need an ERCP, am I the best person to do it? So what about the ERCP selection then? We've talked about patient selection, but what about the endoscopist selection? Well, I'm just going to touch briefly on this. I sit on the training program for JAG in the United Kingdom, in London at the Royal College of Physicians. So many trainees and even many early up and coming service providers regard training in endoscopy and ERCP as well as a numbers game. So, and the number regularly repeated would be 180 historically in America, or 200 in Australia, or 250 later in Europe, or 300. But basically, we need to move away from this. It's much, much more than a numbers game. If we were ever to use a number, it would be much better that we say that that number allows that individual to be assessed for competency. Not that they've gained competency, but that once they've reached the 300, this is the time that we start to look whether they are fit for practice. So an ERCP person may be fully trained and they may be fully competent. So that's great, but what does that mean? Often they're fully competent up to simple level 1 ERCP, and it may take many years and focused training and focused mentoring to get them up to an advanced level. So people who perform ERCP need to be aware of their own level. And when they fail at a particular procedure, they need to be cognizant when they say at a meeting, this cannot be done, because what they actually mean is, this cannot be done by me. But there are sometimes other people out there that may be able to help. And yes, they may be right, and it may be looking at an alternative access. So what about the ERCPist? What would I look for in the ERCPist who's going to do my ERCP? I would want them to look at my imaging themselves, not just to read the report. I would want them to partner up with an HBB radiologist in their trust. And that's often a radiologist who attends your regular weekly MDT meetings. A radiologist who's got time, who's got patience to go through the things that you are asking them. And so I think for people who are trainees and early service providers, getting into the routine of reviewing all of the scans yourself is, I think, a very, very important step forward. And certainly something I would be keen on if they're about to do my own ERCP on me. And I think one way to do this as we are in training doctors is if we ever order a CT for our consultant on the ward, then when it comes back, before the consultant comes, look at the images first, then look at the report and start to see what the radiologist sees. This is not about learning radiologist or becoming a radiologist. It's about becoming streetwise, for example, to the language that radiologists use, but also to anticipate pitfalls, those adverse events that can occur pre or during or after ERCP. So prepare, prepare, prepare. So this is a picture of a mill. This is my wife's father or my father-in-law's mill in Germany. And I wanted to do a picture of the internal opening, but it is surrounded by silos and therefore the light is very, very poor. So what I wanted was an impression of sunlight and also an impression of light within the mill itself. And this is all delivered by flash. So there's a flash off to the left and there's a flash all the way back in that little room at the back, just to give context and to give a sense of depth. And the reason why I picked this up, I know that I talk a lot about photography, but photography essentially is about preparation. It's not just taking the click. So we're coming towards the end. So what are the tips and tricks for patient selection? So we've talked a little bit about looking at the imaging. So what about this? So we don't have the imaging because it's at another hospital. We only have a report. Well, we can import those images via PACS teams. If we don't have a PACS system or we don't have a digital computer system, we can get hold of the hard copy scan images. Or when the patient is transferred over from the hospital, then the images and hard copy scans hopefully can come with them. We do need to see the imaging ourselves. Another referral for an ERCP, but it was an interval ERCP, and now we've realized that the patient has had no imaging for 3 to 4 months. Well, the ERCP may have been appropriate 3 months ago, but it is not necessarily now. So we need to think carefully about whether we delay that ERCP if they're on my list tomorrow and get up-to-date imaging, or delay it by a few hours or a few minutes until we can ascertain whether imaging can be updated. Same for blood tests. Again, sometimes we get referrals from another hospital where there have been no recent blood tests, but these are mandatory. We need to know that there's no coagulopathy, and in the unwell patient, we need to know that there's no acute kidney injury. So bringing it all together, so case 2. Dear Ray, please see this patient. This patient has had an ultrasound, a CT, and an MRCP because they had discomfort. On the imaging, they had a dilated common bile duct and they had a dilated main pancreas duct. So all roads led to the papilla, or the major papilla. The duodenoscopy showed an ampullary adenoma with low-grade dysplasia. Sometimes I will get referrals and the referrals will say, please accept this referral. I had this from somewhere 200 to 300 miles away from a distant hospital. Please see the high resolution images that we have supplied. And the high resolution image was of a small polyp. It was very difficult to see the high resolution because there was a layer of mucus on the lens of the endoscope. And it was very difficult to see that single image, and it was very difficult to see actually what that image was. I think in these cases, it's mandatory that we have a look ourselves. And on that particular patient, they had, for me, a world's first of an ampullary adenoma in the major papilla and an ampullary adenoma in the minor papilla. Unfortunately, I didn't write it up. And 2 or 3 years later, someone wrote up a dual papillary adenoma in GIE. So this patient was referred to Bournemouth for a combined endoscopic ultrasound and ERCP. So here is the question. Can we just walk into the ERCP list and assume that it's all sorted? So let's look at bringing all of this together. What do we really need to do for a patient like this? Here's another example. I want you to think about what actually went into this following work. And yes, it is a picture. This is a picture of one of these stacks that rises at about 50 meters out to sea on the Dorset coast. This is approximately 30 miles away. So what was the work that went into this? Well, number one, I had to drive there. Number two, I had to park the car. I had to walk around Lulworth Cove for 40 minutes across the Pebble Beach. I had to climb up the hill. I had to walk across for 50 minutes up on the elevated fields. Then I had to get down, scramble down the other side. And then I had to get into this position and set up my tripod 1 hour before sunrise. So just like ERCP, we have to prepare for adverse events. I always prepare for adverse events when I come here, and yet I still, every single time I've been here, I've fallen into the water, but I've still kept the equipment safe to be able to get this picture. Now, why do I tell you this story? because the preparation for ERCP, I think, is very, very important. So in the second case that I've told you about, what would I do in the workflow for an ampullary adenoma? So I will actually meet the patient. I will do that staging endoscopic ultrasound and duodenoscopy. I will do it on a sedation list, and I'm just going to look. I'm not going to take any more biopsies, but I'm going to look at it myself, work out what is required and whether I can do it. I will then meet the patient and family on that day. I'll discuss the findings, and I will highlight the management options. But those options will be the following: conservative, walk away, or conservative with surveillance, or we do the ampulectomy with MPD stent, or we do a Whipple's procedure. And then I will discuss the risks of ERCP, and I will tell them about the standard pancreatitis, hemorrhage, perforation, and sepsis. And then I will tell them, it's probably the only procedure where I tell them about my own adverse events over the last 18 years. The 4 bleeds, the 1 pancreatitis, the 1 perforation, the 1 sepsis. And incredibly, when I tell people about this, invariably, well, always they want me to do it, which I always find surprising. But I don't do it. I take their case back to the hepatobiliary MDT meeting, because it's important for high-risk procedures that we have consensus. And I would urge people who are starting out on ERCP, who are beginning their work, that this is a very, very dangerous procedure. And it's important to have consensus that we're doing the right procedure in the right patient and that they are the right person to do it. So having the support of your colleagues, the cancer surgeons, the hepatobiliary surgeons, radiologists, and your own colleagues is of utmost importance. So do we have consensus? If we do, then I book the ERCP under general anesthetic, and I schedule how long that will take. I will book 3 days for admission to watch for bleeding. I had 2 adverse events in the first decade, and after that, I refused to send them away over the 50 or 100 miles that people refer, because I want them to be close for any evidence of adverse events. It's rare, and I'm probably being overcautious, but it has paid off. Post-procedure, I'll give them PPI therapy, and on discharge, they won't be allowed to do any heavy lifting for 10 days. I sometimes get patients, I often get patients out of area who are flown in, and they say, oh, I'm going to fly back that day. And I'd say that's no problem, but I'm not going to be the one to do the procedure. And then they get it, and then they agree. So recently, just coming towards the end of the talk, we had a symposium with our lawyers in Bournemouth in November last year, and there were 150 patients in the audience. And the lawyer said, how long do you take to consent? And the consensus was during a consultation, maybe 15, 20 minutes max. And I said 6 weeks. And I was surprised that everyone fell about laughing. And then the place went quiet when the lawyer said, you are the one that I will defend in court. So I'll leave you with that. What do I see when I walk into our ERCP room? I see risk. I see risk in terms of, have we done the right indications? I see risk in terms of, have we got the patient selection right? And I think if we do, then that will bode well for a successful ERCP. I don't know if anyone would like to make a guess as to how many flashes are used in this picture. So I'm going to use my pointer. I don't know if you can see, but this is my pointer over my head here. So what this highlights in ERCP is that it's not just about me. It's not all about me. It's a team. It's the anesthetic helper with the anaesthetist, with the nurse, with the radiographer, and a cast of thousands behind us that you cannot see. It's about getting the right position. It's about getting the patient comfortable. It's about optimizing them with fluids. So has anyone guessed how many flashes were involved in this? So there's a flash, and this lady, just to highlight her here and separate her from the background, there's a flash behind here on the wall to separate the anesthetic team. There's a flash on the C-arm to show the C-arm. There's a flash on the C-arm and a flash on the C-arm here. And there's another flash there, which I'd forgotten about. And then the most crucial flash is the one that you cannot see, which comes across here and just highlights the three individuals there. So this is all about preparation, and it's all about getting it right before. So I had a small handle there, so I finished my sphincterotomy, and then I pressed click and I took the picture. So in room 11, we call this procedure ERCP. In photography, we call it a self-portrait. So in conclusion, we need to have the right patient. We need the right condition. It needs to be done at the right time. And I think it needs to be done by the right person. We need a good indication to do that ERCP, and we need good patient selection. It may be that we've ticked all of the boxes, but the patient isn't ready. They need to be optimized, or they need to be delayed because of problems with their clotting or whatever. We need up-to-date bloods and imaging that we're confident highlights the reason why we're still doing it. And the patient needs to be fit enough to do it. So thank you very much. And I hope that this has been helpful just to stimulate ideas about indications and also patient selection.
Thank you, Ray. Thank you very much. That was the best possible presentation I could ever have had on a complex subject like indication patient selection, which otherwise looked so complex and boring as well. But you have made it so interesting. And the slide that you have presented, that so many flashes for taking a single photograph, this just highlights the amount of depth that you have to see in a given patient for a procedure like ERCP. I confess always that in ERCP, every time I go to the patient, I'm always apprehensive. It's not like other procedures. ERCP is different. In a given day, for the most easiest patient, one can fail. And it's very important to understand that towards the end of the day, we do ERCP to help the patient. We are
Yes,
not
I
there
absolutely agree.
just for the sake of doing the procedure. And the way you have tackled the message that you've given to the young fellows who are there on this panel, they are all very important, and I'm sure that they are going to understand the complexity and importance of picking the right patient, when to say no, and the most importantly, when we are looking at the CTMR ourselves, that doesn't mean that we are taking over the role of radiologist. We're just trying to help the patient. We're trying to make a roadmap in a proper way, and that's the most important thing. There are a few questions on the panel. One is, what should be the position of the patient if the patient has been sedated, especially if the G has been given? Okay.
So what is the position of the patient once sedation or GA is given? So the traditional way that the patient should be on is what I would term prone. So some of our anesthetists call that the swimmer's position. And so they're not lying flat as such, but they are lying prone, more looking towards the right-hand side. So lying prone in that position is optimal. And there is a reason for that. It opens up the duodenum and gives better access into the duodenum. Now, there is no doubt that you can do an ERCP with a patient lying on their back. There is no doubt about that. I think for trainees and for people beginning service providers, being in the prone position, however, is better. Very occasionally, anesthetists will be happy to do the patient, but they do say the patient is too unstable. They're on inotropic support and their blood pressure is going up and down. And this is truly an emergency procedure. So that is one good example where doing the procedure on their back is an alternative. When you do that, you will really be looking, can you see my picture here? So if we look at the picture here, this patient is on their back. Now, if they were on their front, then I would have to turn and look behind me because the duodenum is in a slightly different orientation. So it is helpful to have a monitor here for standard ERCP, but we now also have an alternative monitor here in case we have to do exactly that. So I don't know if that helps. Just to finish that question, if the patients had a general anesthetic, they will be tubed and ventilated on their back, and then we will turn them, and we have roll covers, so we don't manhandle and lift them. We have a technique to roll them by the use of special slide sheets, and that works very well, whatever their body mass index.
Right, there's another question that what is your policy in terms of antiplatelets, anticoagulations, when to say no to ERCP?
Yes, okay, so that's a good question. So if a patient is in multi-organ failure, they are coagulopathic, and you're asked to do an emergency ERCP, you may not have a choice. You may have to do it there and then. And so what you can do is, if the multi-organ failure is deteriorating every hour, then you really don't have time. So number one is I would give the I would try and reverse the clotting, but often in multi-organ failure or sepsis, it can be difficult. Giving FFP can help, but what we will do is we'll go in to the common bile duct and we'll put a stent across, and we'll just allow drainage of pus, and then we will walk away. So, and often you'll see over a period of a few hours that the sepsis starts to improve. For those who have thrombocytopenia, so low platelets, if they are under 50, then I'd be happy to do it. If they're less than 50, say 25 to 50, we might do the ERCP and stent, but we wouldn't necessarily do anything else. For patients who have biliary obstruction, but they have a hematological disorder, then we need the help of the hematologist to sort the low platelets in the first instance. The other thing to remember is that patients with acute kidney injury or chronic kidney injury, even if the platelets are whatever over 100, the higher the creatinine and lower the EGFR, the more these people will have an acquired platelet defect. So the platelets may not be as sticky as you anticipate.
Yes, just a quick hi, Ray.
Hi.
Excellent presentation, Ray. Ray, 2 points. One, you highlighted two very important points. One is the selection of the patient, but also selection of the ERCP is.
Yes.
And if we know that our limitations, our complications, and our success will gradually improve.
Yes.
I believe very strongly. And one of the problems we have generally is that we generally do things that we have seen and we say, well, why not? And there are peer pressures, etc.
Yeah.
I just want to share one case, and this is a patient that was sent to me with cholestatic LFTs, but no jaundice, high alcohol, dilated CBD till its distal end, dilated PD, and possible pancreatic, possible ampullary lesion. This patient underwent ERCP. This patient had a small sphincterotomy and a stent placed. And this is a 45-year-old man. So the CT scan showed nothing except abnormality at the ampullary area. What would you say? This patient was not jaundiced. Did he really need any Ercp? Should he just have had an ampullary biopsy using a duodenoscope? Or at the most, US, I don't think that was also needed because the CT scan was pretty good and clear. This is a fit 45-year-old man. What would your views be on that?
So, Saad, that's a really, really good question, because you and I both know this is actually not rare. You and I both know that these cases come up all the time, and there are a number of levels to this question. The first thing I will say, and again, it's to trainees, but also to the new doctors who are starting out, is that they will be a new ERCPist in their hospital, and they are the new kid on the block, and a senior consultant or Professor Gias will come down and say, I'd like you to do an ERCP. And it's very hard to say no when you have when you're feeling nervous about the case. But the thing I would say to those trainees or to those new qualified or young consultants is stand your ground. If you have bad feelings about or nervous about a case because it's too difficult for you, or because perhaps the patient doesn't need it or they don't need it now, then stand your ground. The other, the next thing to say is when a patient isn't jaundiced, and if a patient is well and there is a question in your mind, then we need to know this. Know that you have time and know that the patient has time. So if you have time, you can walk away. You can walk away until you have more information and decide what to do. Now, if we come back to your case now, what would I do? So I don't know the answer to the case. It would be it would be good. That's the kind of case where if you phoned me and we're in the same hospital, I'd say, right, I'm going to come to your office. Let's have a look at the images together, and we would need to know the following. So we've got I think a dilated duct and deranged LFTs. Is that right? And a dilated MPD, but no jaundice, no sepsis. Is that correct?
Absolutely.
Okay. And the question is, I think with a dilated CBD and a dilated MPD, then all roads do lead to the papilla. Now, if we cannot see anything on MR, CT, transabdominal ultrasound, then having the facility for endoscopic ultrasound, preferably, I think is helpful. What's interesting?
Showed an ampullary.
They had a what, sorry?
CT scan showed an ampullary lesion.
Yes. So I would, I think that doing an ERCP is actually helpful, or doing a duodenoscopy and going down and evaluating. The endoscopic ultrasound will help to see visually, does it look like an adenoma? Does it look like an adenocarcinoma? And it will also be able to stage. The ERCP will be able to get high resolution endoscopic images, and it'll be able to evaluate whether what it looks like. Does it look like cancer? And yes, of course, you can take biopsies. The problem I have is not quite this case, but it's the case of cholangiopathy or pancreatopathy, where we're suspecting IgG4 related disease, and there is often a request to go down and biopsy the papilla. And the problem with biopsying a normal papilla is, number one, it often doesn't highlight IgG4, and number two, it can cause acute pancreatitis. How am I doing? Did I answer any of that question correctly?
The point I was making was, does this patient need stenting? And that's where my point was.
Yes.
And I personally feel that this patient did not. All you needed to do was, in a 45-year-old man who you are suspecting to have ampullary tumor shown on CT scan, you go down, have a look with your duodenoscope. You've seen an ampullary growth. You take a biopsy and you come out.
Right. Yeah. Agree.
Putting a stent is a palliative procedure for relieving jaundice. This patient has no issue at all. This patient should ideally be, as you said, if you want to do an EUS, fine. If not, you really don't need to do that either. This patient needs to go to MTT, and probably what he needed was a Whipple's. Now, by putting a stent, you've increased the chances of having complications, unnecessary procedure. I read this scenario to you because the question here was whether this patient really needed cholangiogram or needed a stent. There was no question about stones here. There was nothing like that. It's clear cut. So I think if you're suspecting that, and even if you did, you went down and you found an ampullary growth, then I personally feel if it's not an adenoma, you don't think this is something that can be removed by ampulectomy, all you need to do is just take biopsy and come out and then basically sit down and see if this patient can directly go to surgery rather than actually increasing the risk of a procedure. And the point you very well made, the problems occur in patients who are actually incorrectly selected. And what happened with this patient was that this patient had problems and unnecessarily actually had issues. And I raised this point here that, if the patient and this is not a junior doctor, so this is not somebody who started. The point is that you need to stop yourself. The fact that you see ampulla, you see a dilated CBD does not mean you need to get in always. Sometimes you can take, that was what I wanted to highlight.
So I think that's a great case, and I wholeheartedly, totally agree with all of that. I think that even when we are asked to do an ERCP, and again, this is directed at trainees and new people in the hospital as consultants, is although the patient's consented, although you've gone down, when you suddenly realize that you have an unanticipated problem like an ampullary adenoma, that you do not need to do the ERCP, even if the patient's consented, even if your older, more senior colleagues have asked you to do it, you do not need to do that. And there is ample evidence that if you unnecessarily stent a patient who does not need it, then you can create problems for the hepatobiliary surgeons at a later stage. So I think when it's about being conscious and cognizant of this issue of having time and having time to walk away. And I think what I would say to people who have never been in this scenario before, you are the one in the hot seat, and you are the one who is open to medical, legal, or legal challenge. And the hardest case ever to do this is the first. And I can tell you, after you've done it once, it gets easier and easier with time. So learning to say no at ERCP, even when the patient's sedated and tubed and ventilated, learning to say no is a very, very valuable aspect to your practice. And I think I would totally agree in terms of stenting. If a patient doesn't need stent, they shouldn't. And the final thing that I would say, and this is, I'm sure that you would feel the same, is in other hospitals, or even in my hospital, if a patient has an ampullary adenoma, it's very important just to walk away. Yes, you can take a small biopsy. You can take a small biopsy, but do not do a sphincterotomy and do not put in a stent. I would walk away and bring the case to the MDT, because if I'm going to be doing the ampulectomy, I do not want the kind of surgical field altered by a sphincterotomy or a stent. So I would totally agree with you. It's really important to walk away.
Thank you.
Thank you, Ray. Thank you, Saad. We already overshot 11 minutes, and it has been an excellent session. I've enjoyed it thoroughly. I'm sure all the rest of the audience must have enjoyed it thoroughly. I'm getting the messages from all across for the wonderful talk that you've given. I'm really thankful to you for sparing your time. I'm thankful to my co-host, Dr. Saad Niaz, and at the same time, I'm really thankful to all the participants, which includes the senior people like Iltaf Alam and Iltaf Pak and so many others. And I'm really thankful to all of them for sparing time, and at the same time, thankful to the Wilson for providing us the platform for hosting this webinar. I hope that Ray, you'll keep supporting us. You'll keep delivering brilliant talks like these in the future as well. We have a whole series of talks, about 44 of them. and you'll keep coming on this forum to support the education in Pakistan. I'm really thankful to you. I'm thankful to your family for sparing you for us. With this, goodbye from all of us, and have a very nice evening.
Thank you. Thank you so much. What I will do is I have this talk. So if any of you would like a copy of this, shall I email it to one of you so that you have it in your slide set? Would that be helpful?
Yes,
That would be
certainly.
great. Thank you.
Will be, but then the whole session has been live telecasted out on Facebook, and this is
Okay.
available on Facebook for the viewers to come back at a later stage as well.
Oh, perfect. Okay. Well, thank you again for asking me. It's been a great privilege.
Thank you. Thank you very much. Take care. Bye bye.
Take care. Take care, everyone. Thank you. Bye-bye.